Good morning, folks. Thank you so much for joining us on Friday, March 24th. My name is Kelsey Berkfeld. I am the Director of Advocates for Ohio's Future. Very excited to be with you here today with my colleague, Sarah Hudasek, to present and feature two of our fantastic members here at Advocates for Ohio's Future. We have Beth Kowalczyk from the Ohio Association of Area Agencies on Aging, as well as Jordan Ballinger from Disability Rights Ohio, joining us in just a minute. Before we invite them to join us, I just wanted to give a few housekeeping rules. As always, we will be recording this webinar in full, and we will send out the webinar as well as the slides in full later this afternoon. And also wanted to give you a quick update on where we are in the budget process. I know it feels like it's been a very long time already, but we are finishing up the initial process in the House. The House Health and Human Services Committee finished their work in that budget subcommittee this week. And then we have one more week of hearings in the legislature before they go on spring break for those next 2 weeks. So probably around mid-April is when we will see that first sub-bill. So the House's first round of changes to the budget bill, I know we are all eagerly awaiting. Here at AOF, we will also be taking a spring break during that time, but we will come back with you after we see those first round of changes in the budget to share what we see, opportunities for advocacy, and an update on the process moving forward. So folks, without any further ado, I'm very excited to introduce Jordan Ballinger from Disability Rights Ohio to jump into the wide world of home and community-based services and the history behind it, and really why they're such a vital part of the care community and making sure that those opportunities are available for all Ohioans. So Jordan, whenever you're ready, take us away.
Thank you, Kelsey. Thank you, Sarah. Thank you, AOF, for hosting Beth and I. I'm super excited. I don't often get to talk about the history of Ohio's HCBS system, which some of the history isn't actually entirely the HCBS system, but how we got our HCBS system. My name's Jordan. I'm the Policy Director for Disability Rights Ohio. And Disability Rights Ohio, just for those of you who don't know, is the state's protection advocacy system. We advocate for an equitable Ohio for people with disabilities. So next slide. So like I said, I'm going to do a really quick, brief overview of some national history and how it impacts some local and state history on the HCBS system. But I would be remiss if we didn't go back a long ways to talk about pre-institutionalization or prior to institutionalization, what was occurring. Largely in the US, early America, most disabled people were kept either in poorhouses, their own family homes, or left on the streets typically. They were lucky if they were part of a high income family. Usually those families helped provide more care for individuals. However, jumping ahead into the 1850s, an individual by the name of Dorothea Dix advocated for humane treatment of disabled people. And this began really the wide construction of state institutions across the country. She went to pretty much every state legislature and lobbied for the creation of these state institutions. And so in 1803, so a little before Dorothea Dix comes into play, Ohio is admitted into the Union, and Ohio in 1815 begins constructing its first hospitals. This is what they call them at the time, which are state institutions. They're not at the time state run, they're provided state funding, and they're locally operated. And there's the hospital, the first one is in Cincinnati. Next slide, please. So that kind of kicks off several years, a few decades, almost 100 years of construction of institutional settings in the state, including the first big one, which is the Ohio Asylum. And within our Constitution, which is language that still exists today, states institutions for the benefit of the insane, blind, deaf and dumb shall always be fostered and supported by the state and be subject to such regulations as may be prescribed by the General Assembly. So essentially, this set out the role of the state in providing quote unquote services to people here in Ohio, which again continue to grow construction of state institutions. So over the next few years, we see institutions go into place in Cleveland, Dayton, Athens, Toledo, and Massillon. However, with the expansion of these facilities, there was a need for oversight within the state. Many of these were kind of overseen by a board of trustees without a lot of state oversight. So in 1911, the state creates the Department of Public Welfare, and this kind of takes over the administration of our state facilities, and the state really becomes the controlling force of state institutions here in Ohio. Throughout the 40s, the system continues to expand with more institutions being put in, with more people coming into institutions. And then this side of the Ohio service system becomes so large that in the Department of Public Welfare becomes so incredibly large. And because of the issues with funding into these service systems, the state creates the Department of Mental Hygiene and Correction. So this now oversees all institutions within the state, those that provide quote unquote services to disabled people, as well as our correction facilities. Next slide. So the period that we are now in, that all of us consider to be in, is deinstitutionalization, or the building out of services in our homes and communities. And that really is spurred in the 40s and then really developed in the 60s. So in 1946, there is a National Mental Health Act, which essentially is an act that sets out to do a ton of studies on what are we doing. Is institutional care the best way to do this? What do we need to do better? How can we be more effective? Because we're starting to see these large institutions become less of care settings and more of warehouse type settings, where people are just being put in there and not receiving their basic needs met. So in the 1960s here in Ohio, another report was issued, which is the Caring for Youth and Horn Report. And this set way for how Ohio's system currently looks today, because what this report found is a desperate need to invest into home and community-based services and move people out of institutions and focus on ensuring people have access to services in the community. One they make is not only at a higher quality of life, but also a cost savings for the state. In 1965, the Older Americans Act is passed by Congress, which is really a response to economic and social needs of adults here in America. And because of that, Ohio in 1966 created the Division of Administration on Aging underneath the Department of Mental Hygiene and Correction. So this is Ohio's kind of initiative to bolster services for older adults. Its first real initiative. Then in 1967, probably two of the most important pieces of legislation here in the state were passed: Senate Bill 640 and Senate Bill 169, which create our mental health and DD boards. That's not what they were called at the time, but I refuse to say that word out loud. So they are creating, and this is really putting a focus on community-based hubs for HCBS services here in the state. And this is only bolstered in the 70s when Medicaid and Medicare are passed, and specifically 1972 amendments that allow for home and community services to be provided. However, there is still an institutional bias within those that language of Medicaid, but this is the piece where federal funding starts to flow into the state. Next slide. Okay, so I'm going to run through these relatively quickly because there's a lot here, but this is all of kind of the really important pieces of legislation and things that occurred here in Ohio and nationally. The creation of a new department in 1972 for mental health and DD, In 1973, there is the creation of the Commission on Aging, which kind of pulls it out more and it becomes its own entity. In 1973, we have Section 504 of the Rehabilitation Act passes, which essentially sets way for the ADA, or the Americans with Disabilities Act. In 1975, we have the DD Bill of Rights, which really just lays out that people with developmental disabilities have a right to be in their community and receive care in the least restrictive environment. In 1980, we split up the departments to have mental health and DD as one department and then corrections as another. And then in 1982, we have our first senior property tax levy passed in Ohio, followed by the Department of Aging in 1984, which still is the current department today. And then for the mental health system here in Ohio, one of the most important pieces of legislation in the state is the Mental Health Act of 1988, which just completely re-envisions how community-based services are provided here in Ohio. And in the implementation report of 1991, already they are finding that the General Assembly in the state are not providing enough resources to really ensure those with mental health diagnoses are able to leave institutions and be cared for in their homes and communities. And then in 1990, we of course have the Americans with Disabilities Act. 1990, passport waiver goes statewide. 2013, there's a new department for mental health and addiction services. And then there's also the Department of Developmental Disabilities is now its own agency. And then in 2014, we see the introduction of managed care. Oh my gosh, I almost lost the word. Managed care through the My Care Ohio demonstration. And I think that is all for me. I will turn it over to Beth.
All right, thank you, Jordan. And as you can see, there are so many different facets to home and community-based services, and it has a rich history. And one of the things that I like to point out is if you look at where we are in the 90s, where it was almost 90% of people were living in institutions, particularly older adults. And now we are at more people that are living in the community, around 63% or so are living in the community as opposed to institutions. So there's been a lot of shift and we still have a long way to go, but these are vital services and there's so much information about each and every one of them that we can't possibly cover them all today. So what we're going to be doing is really high level. But let me introduce myself. My name is Beth Kowalczyk. I'm with the Ohio Association of Area Agencies on Aging. I'm the Chief Policy Officer. And the Association of Area Agencies on Aging, as we call it, O4A, is a nonprofit statewide network of agencies that provide services for older Ohioans, people with disabilities, and their families. The association engages in national and statewide advocacy to address issues which have an impact on the aging and disability network and older Ohioans and people with disabilities. We provide services to members and we serve as a collective voice for Ohio's area agencies on aging. And as I said, any one of these topics could be its own webinar that we're going to be talking about. And I know even probably in the participants today, we have some folks who are probably more knowledgeable about one area than other and may know more than me. But I do encourage you, if you want to do a deeper dive, to check. We have some trainings for the Aging Network. We have one on DD. We have one on Medicare. We're looking into the veteran system, which isn't even covered in this slideshow today, but is its own set of programs. So I encourage you after today to seek out more information if you're interested on any of these items. Next slide, please. And so what are home and community-based services? There's a huge range of services that enable people to live in their homes instead of living in a nursing facility or other institution. And they range from a wide number. And this is the most common ones, I think, but there's in each of the programs, there may be some others that aren't listed. but really personal care, helping you with the activities of daily living, homemaker services to help you with home, taking care of your home, transportation, home delivered meals, minor home modifications, case management of all of the services, respite care, adult day services, emergency response. That's like the button that you can have if in an emergency that you can use, social work, counseling, medical equipment and supplies. I mean, I don't have everything on here. There's chore services, there's pest control, there's a whole host of things that could be under the home and community-based services umbrella. Next slide, please. So why are home and community-based services so important? They enable people to live in their homes and communities, to maintain their connections with their communities, with their neighborhoods, with their families. It helps people maintain their own independence and control, and improves the quality of life and health outcomes for individuals. And it also enables people to give back to their community. In any number of ways, so that it really emphasizes the value of people, regardless of their age or ability. And I have in the middle there, it says it's cost effective. I mean, that is very important, that it is much lower cost to serve people in the community than in an institution. But I think the focus on how it benefits individuals in our communities is of primary importance. So next slide, please. So we're going to move on to types of home and community-based services in Ohio, and this is going to be like a wide grouping of a coverage of different types. And it really is divided by payer source, so who pays for these activities or these programs. Under the umbrella of Medicaid are a number of services or waivers that they call them waivers because the Medicaid program does not recognize them as an entitlement or a service that must be included in the state's Medicaid plan. The state has to submit a request for a waiver from federal requirements to include these types of services. So I think almost every state has some form of these waivers in their Medicaid plan, but they're all very different. There's legislation right now at the federal level that proposes to make Medicaid home and community-based services an entitlement, so that just like with nursing homes, if you're eligible, you will get the service. And there will be no question that the state has to provide it. But right now, that's not the case. So we have a list of different types of services that you can get under a waiver program. We have the Ohio Home Care Waiver, which provides services to people with disabilities ages 59 and under. You have the Passport Waiver. Passport's actually an acronym, which I'm not going to explain right at this point, but suffice it to say, it's an acronym for the waiver for older adults, people 60 and older. Assisted living waiver is for people ages 21 and older, and it provides support for individuals living in an assisted living facility. And we call this home and community-based services because it really is a transition before you would get to a full service nursing facility. And so we include that in our home and community-based services list. My Care Ohio, as Jordan referenced, is the managed care demonstration program that the state has for individuals who are on Medicaid and Medicare. So that includes people with disabilities and older adults who qualify for both programs. And it's a demonstration program that is being conducted in 29 counties in Ohio. It includes waiver services for people of all ages. And so it is just a different way of delivering the services. I'm going to skip state plan services for a moment. It's got a little asterisk there for a reason. The last three individual options, level 1 and self, are developmental disabilities waivers. So those are waivers for people who are people who have developmental disabilities, and it's typically determined by the age on which your disability occurred. So for people, I think under 22 generally, and individual options and level 1 are varying ranges of services depending on your level of disability. The self waiver is the self-empowered life funding waiver. And this is a waiver that allows for self-direction, of the ability to hire and identify your own services and control how you use those services. Okay, next slide, please. Oh, wait, go back. I forgot one. Go back to the, okay, state plan services. That's the one exception to my list of waivers. It's actually what's in the Medicaid state plan. There are some home health services that are in Medicaid state plan services that if you're eligible for Medicaid, the state has to provide them. They're very limited, but there are some home and community-based services within that program as well. So if you don't qualify for a waiver, you may be able to get some limited state plan services. Okay, next slide. Thank you. There's some non-Medicaid HCBS. Remember, Medicaid can pay for those waiver programs, but these are programs that are not funded by Medicaid. They are either funded by federal, state, or local funds. Jordan referenced the Older Americans Act. The Older Americans Act has funding that is provided through the area agencies on aging, and then the area agencies on aging contract with service providers to provide services to people 60 and older. And those services can be home delivered meals, personal care, home repairs, transportation, tour services, many of the same things that I identified through that list of home and community-based services. And that is for people 60 and older in the community. And the area agencies on aging develop plans based on needs assessment to identify who the providers are, what services will be provided, but there's a whole host of things that are available to people in the state. Senior levies, that is the program where counties or other municipalities put property tax levies on the ballot to fund senior services. And as Jordan mentioned, in 1982, Claremont County was the first to do this. And we now have 74 counties that have levies in their community that provide additional supports. And they're very different depending on the county, but many of them, some of them are managed by area agencies on aging, others by other local county offices on aging or other entities, but many of them also provide home and community-based services. There are other programs in the community, depending on your community, that could be providing similar services through other programs. And then there's also private pay, where if somebody can just identify, say, home delivered meals and pay for them themselves through a local, state, or national company or something. I don't have on this list, I do have a slash for other. I don't know as much about these programs, but I did want to put out there that there are programs within another department called Opportunities for Ohioans with Disabilities. There's something called the PCA, the Personal Care Assistance Program, which is for people with disabilities who need support while they're looking for employment or participating in training for employment. People may be eligible for a personal care attendant to assist them. And then there's another program called Independent Living Services for older blind Ohioans that you can access also through that department. Okay, next slide. So how do you access these services? We'll move to the next slide, because this is very important. We do have a system called No Wrong Door in Ohio, where if you go to a local agency, many of them should be able to get you to the right agency. So if you come to the area agencies on aging and it turns out you're eligible for a developmental disabilities waiver, then they should be able to help you get to where you need to go to apply for that waiver. But area agencies on aging are a a place where you can go to find out all things about aging, but also for people with disabilities and other questions about home and community-based services, you can go and contact your local area agency on aging. We have 12 in the state that cover the state. There are also county departments of job and family services in each county. Their main responsibility is eligibility for basic public assistance programs, including Medicaid, SNAP, Ohio Works First, child care, and many others, as well as some other services that they provide. But you can go there to apply for Medicaid, which can get your process started also for applying for a waiver. You can contact your county developmental disabilities board as well to get you connected. And then finally, we have centers for independent living across the state in various regions. And for people with disabilities, it's an opportunity to find out what you're eligible for, both in terms of helping you with seeking employment and getting assistance with home and community-based services. All right. In order to be eligible for these various waivers or programs, there's typically an age requirement or distinction, as in Ohio home care waiver is for people under 60, passports 60 and older. But they vary depending on the programs. There is also typically a functional eligibility assessment to determine what level of care you are at. And that is important because some of the waivers require that you be at a nursing facility level of care. And what that means is that you would be eligible to receive services in a nursing home, but you will qualify then for particular waivers, including passport and the Ohio home care waiver. And developmental disabilities has a level of care as well. So these are to determine what activities of daily living do you need assistance with. And then if you meet a certain level, a threshold, then you're eligible for the various waivers. Now, some of the local programs may not have as strict requirements regarding those activities of daily living or level of care, but they will look at what your need is. And then finally, many of them are income-based programs. So that is a Medicaid determination, or it could be through a local program. If you're at a certain level of poverty, you may be eligible for those programs. All right, we can go to the next slide. And then finally, I just wanted to talk about the process. There is an application process. Typically, you will have a screening to see if you're potentially eligible and for which program. You may be referred to another agency for further review. And then there's typically an assessment of your need and if you're eligible, you qualify, then a service plan or some kind of plan will be developed for you with those types of services that you might be getting. And then arrangement of those services. And I know with the area agencies on aging who administer the passport program, those services are managed through a care manager. So they keep track of all of it and help the individuals ensure that they're getting the services they need. Okay, I'm going to hand the next slide over to Jordan, and he'll be talking about the numbers.
Thank you, Beth. I think one thing I want to highlight before I jump into the numbers too is you'll notice that these waiver programs we're talking about for HCBS only go across 3 systems of care. There is still one large system of care that does not have an HCBS waiver at the moment, and that is the mental health system. There is a new program, the Ohio RISE program, which is targeted to youth with complex behavioral health needs that has a 1915C HCBS waiver, but largely the mental health system is structured very differently. So home and community-based services within that system and how you go about accessing them also looks a lot differently than the systems that we've been talking about today. So in terms of number of Ohioans on waivers here in the state. There are a little over 141,000 Ohioans currently on a home and community-based services waiver. In the developmental disability system, that is about 51,000, with the largest portion on the individual options waiver. And this is also just the largest, most flexible waiver in the DD system. Over 19,000 on the level 1 and a little over 3,000 for the self waiver, which is the smallest waiver in the DD system. For Ohio Medicaid, the MyCare Ohio is the largest waiver system with over 38,000. And then the Ohio Home Care has a little over 10,000. And then Passport over 37,000. And then the assisted living waiver over 5,000 people. So as you can see, there's a lot of people being served in our HCBS system through the waiver program specifically, and through each of these different agencies. And we'll talk more about the complications of each of these systems as well, and why it is so difficult to go from one system to the other or receive similar services from one waiver from the other. Next slide, please. So this is the average cost breakdown for each of these waivers. This was actually put out by the Ohio Department of Medicaid this year for their House Bill 33 state budget request. So they did an HCBS white paper, and this is the breakdown that they gave of all of the HCBS waivers. As you can see, as I stated, the IO waiver is I don't want to say most expensive, but has the largest average cost of any of the waivers currently in Ohio, with around $65,000. It's also a very flexible waiver, allows people within the DD system to have flexibility in their selecting their services, where they live, transportation, all of those things. For level 1, there's about $11,000 on average, and then self $14,000. There is no data specifically for how much those on MyCare Ohio waivers, the average cost is, because it is through managed care. But in the other ODM waiver, Home Care, Ohio Home Care is $17,000. And then for the Department of Aging, the 2 Passport is over $10,000, and then assisted living is $11,587. So that's a little bit about of HCBS currently, who is in the system, how much money each of these individuals get for the current HCBS system.
So Jordan, I suggested we would take comment or questions now, I think, before we move into current issues, because it seems that way we can clarify some things.
That sounds good.
The first one I see, in the questions and answers, and I'm taking this one because it's on the area agencies on aging. How can we make sure that area agencies on aging get trauma-informed care? I think that's a great question. We've started to receive some information and be involved in some working groups on this. I'm not sure it's the identified specifically in the state plan on aging, but that would be the way to get it prioritized at the state level. And then also, as area agencies on aging conduct their needs assessments, that's another way to provide feedback on the types of things that communities think that they should be focusing on. Definitely something I will take back to our folks. The next question is, what's the move on making HCBS system more ADA friendly for people? And I know that there's some work at the state level with some advocacy groups to promote accessibility. And I don't know, Jordan, if that's something you want to talk a little more about.
Sure. I guess the move is mostly from external factors, like Beth stated, right? It is a large push by advocates to be at the decision-making table. One of the biggest examples, I think, is the task force that was convened last year on the direct care workforce. The initial announcement was only to be interagency individuals, like agency directors, and then after a lot of advocacy, advocates were included in that task force. I know that doesn't necessarily mean ADA, but I think accessibility in this particular realm is having people who receive services be at the table making decisions and overseeing the services they're being provided. So I think in terms of accessibility, that's kind of the largest push at the moment within our state agencies.
And I also think, CMS, that's the federal agency that oversees Medicaid and Medicare, is emphasizing health equity. And I think it's incumbent on us as advocates to ensure that age and ability are included within that discussion. And so, I think we have a long way to go to continue pushing for that. But I know it's even at the basic level in terms of doctor's appointments and access to services, there's still a lot of challenges that we need to address. The next question is, why is it so complicated for people who opt out of MyCare Ohio for Medicare to get services and supports? I'm not sure specifically what challenges you have, but I can say that the goal of MyCare Ohio was to streamline the services between Medicare and Medicaid, basically the who's paying for what and how you get it by putting it under the umbrella of managed care. So if you are part of it and you don't opt out, then you have one managed care company who is organizing both of those things. If you opt out, then you are getting your Medicare in the fee-for-service world, not under managed care. So it's not as coordinated. So that's the ultimate goal of MyCare. And I think there are some challenges when you have dual systems that you're dealing with, and probably even more than just two, frankly. And I think the next one, maybe Jordan, you can address. Why is it when someone with developmental disability ends up in a nursing home, DOD waivers are not presented as an option to them? Hearing all these stories all over the state, and it happened to me years ago too.
That's a really good question. That's an issue that we hear a lot. And I think the largest issue is how siloed our agencies are across the HCBS system. So because nursing homes operate under one particular structure and DD waivers are under another structure, there's kind of a shifting of people across systems, or only providing them options under this particular system. So I know a lot of times when people are discharged from nursing homes, they're presented with options specifically under like the Department of Aging or the Department of Medicaid, and not necessarily the Department of DD, because it's such a different entity entirely with how you go about accessing those county waivers. I know this has also been a huge issue we've heard a lot about, where people don't even know that DD has a waiver program, that people are just kind of automatically put on to things like MyCare Ohio or the Ohio Home Care Waiver without understanding all of the options available. And I think, again, that goes back to the fact that each of these agencies are structured differently. And so they have different things available for people, and they don't always interact with each other, I think, in the most helpful way for people being served. And so instead of providing all of the options at once, it's kind of like a throwing people from one system to the other and hoping that they figure it out, which is a huge problem, which is why Beth and I also, I think we mentioned it in this presentation, have talked a lot over the years about parity across systems and ensuring that individuals don't have to be thrown from system to system and know all of the programs that are available to them, so that they can have access to the best services and supports available.
Okay, the next one is, will you explain again a simplified definition of a waiver used by programs? Please explain it as if I am 5. I apologize for that. These are very complicated programs. I'm going to try one more time, and then if it's not simplified enough, I'll let Jordan give it a shot. So a waiver program is a program under Medicaid. So Medicaid pays for these services. And I'm not sure if you are asking about why it's called a waiver, but that is because it's not included in the regular Medicaid program. A state has to do a separate process to get these services approved for the population they want to serve. And then the waiver is that you would be receiving services under is just a program under Medicaid for home and community-based services. And depending on your age, the type of disability, and your income level, then that may determine which waiver you get. So hopefully that's a little easier to understand. If waivers are not an entitlement, does that mean someone can be denied for a waiver and be forced or have no choice but to enter an institution in order to receive the care they need? Well, that actually is a great follow-up to what is a waiver. They're not, the word entitlement in this term means entitlement in the program itself, the larger program, not by individual. Once the state decides they're going to have a waiver, then they set the parameters of that waiver. So if you meet the requirements, you either are enrolled in the program, or you potentially could be on a waiting list if there are not enough slots for you on the waiver. In Ohio, for Passport, there are no slots. So everyone who applies and is eligible is on a waiver. In the developmental disabilities waivers, there may be wait lists. And so they're different programs, and so they have different parameters. But you are, if you are eligible for a waiver, then you are supposed to be enrolled in that program. So I think that covers that question. Why are there no supports for people with developmental disabilities on Medicaid waivers like MyCare Ohio? They basically carved out developmental disability, so they are not part of MyCare. If you are a person on a developmental disability waiver, you can choose to join MyCare Ohio, but you are not required to. Unlike people who are in, who are older, receiving the Passport waiver or Ohio Home Care waiver. Is there currently a wait list on any systems for waivers? Jordan, I'll let you talk a little bit about that.
It depends, like Beth said, right? Passport, no, but there was at one point a statewide waiting list for developmental disability waivers. They changed how they do that. They changed the assessment tool, and they changed how people access waivers a few years ago. So now there's not necessarily like this large statewide waiting list. However, it depends also on the county you're in. So I did a quick, when I read that question, a quick search of like Franklin County. For instance, Franklin County has a waiting list, but we don't necessarily know how many people are waiting to receive waivers. Luckily, for the past number of budgets, they have expanded the number of waiver slots in the DD system, so more people have access to them, which has, I think, brought down the total number. I think back in 2016, though, there's like 40,000 people on the waiting list. And I think that has dramatically declined over the past several years because of the investment into the waiver slots.
Well, and there used to be slots for Passport until they provided sufficient funding to cover the expected number of people that were on that program. So there is a question of how much funding do you have basically to serve the people that need the service. In many rural areas, we experience a lack of care providers. What measures have the area agencies on aging taking to address the inability to cover hours? Well, that'll be going into our next part, which we'll move into in a second. That is the key challenge we face right now. Why can a person on a DD waiver not get approved for an assisted living waiver? Well, it could be for any number of reasons, but primarily I'm assuming that it would be because there is a different level of care. So different level of uh, your need in terms of the activities of daily living, and the type of disabilities that you may have. And it may also depend on your age. So there are different qualifications. So they're not all equal. All right, I think we've covered the questions at this point. So I'll move into the current issues. And yeah, I mean, I think that the one question really hit the nail on the head, but we've touched on some of these things. Historically, we have not had sufficient funding for home and community-based services, either at the federal level, at Congress, and then the Ohio General Assembly or the legislature. And as we've been talking about, part of that problem is there's still what people call an institutional bias, the idea that we will ensure that there are facilities for people who need care, which is a valid potential place for people who need a certain level of care. But there's a bias towards that as opposed to home and community-based services. We know that's shifting. It's shifted over the years. The numbers are shifting in people who are living in the community, but the funding hasn't followed yet. And so we're in the middle of the state budget, and this is one of the top priorities for a number of our organizations who serve older adults and people with disabilities. And this is occurring even despite the fact that the ADA and the Olmstead decision really mandated that states work to put people in the most, to provide access for people to have the option to live in the community setting. COVID exposed the need for additional funding for home and community-based services. There was an influx of relief funding to support people because people were staying home, and it was really, honestly, pretty dangerous to be in a nursing facility initially. And there was a lot done to address that in the nursing facility, but there was a exposure of the need for more support in the community because people really wanted to stay there. And then finally, there is a lack of parity across our systems. I can tell you that in the aging passport waiver, particularly personal care is one of the lowest paid services compared to the other systems. And so if you wanted to get personal care, if you were a provider providing personal care to someone in the passport waiver, your rate would be the lowest compared to if you were providing services to someone in the developmental disabilities area, or even in nursing homes. If you were a worker who was trying to get the best pay for the work you do, if you do the same type of work across all systems, you're going to get the lowest pay in the area of older adult. And so we're competing for workers, and now there's a shortage of workers. And I'm going to talk about that in a little more detail because that's our top advocacy initiative in this state budget. So we can move to the next slide. Just looking at Ohio's systems that provide personal care, one of those home and community-based services, the programs that the area agencies on aging provide, we did a survey in those programs to see who was eligible for the programs. They're enrolled in the programs, but not getting personal care. And as you can see, those numbers are steadily increasing from 2,000 when we did the survey in February of 2021 to 3,000 in April of 2021. In January of 2022, it was 4,000. And this isn't updated, but in October of 2022, it was 4,500 people. And that was across all of the programs that the area agencies on aging provide. Now, people are getting other services, but personal care is, the most basic service that many people need. And because the workers are paid the lowest, they're really not able to access those services. So let's go to the next slide. And so why are we having a problem with finding workers for this workforce? Really because of the rates that Medicaid pays agencies, and then the agencies have to figure out how much of that rate they can pay to the worker. Workers are really getting the lowest wages, between $10 to $12 an hour. They're living at poverty level. They are accessing public assistance and living in affordable housing, and really are relying on Medicaid, or not, they don't have health insurance. Many of these folks need help with childcare. And so they are, obviously, for the workers that we see, they're going to go to where they can get paid the most and have access to benefits that they don't have in some of these Medicaid waiver programs. You can go to the next slide. And so this just shows for the United States the fact that not only do we have low wages, but this has been going on for a long time, and the wages have not really seen an increase. You look at 2010 across the country at $11.23 an hour to $12.98 in 2020. So as you know, you can't really hire anybody for $10 to $12 an hour anymore, where we're at right now with the workforce. Okay, next slide, please. So just to really further to look at this problem, we've had this situation of trying to recruit a workforce in the personal care space for several years, because the rates have not increased. Except through advocacy of organizations like Jordan's and mine and others in state budgets. The state has not increased the rates otherwise, and the rates are still very, very low. The rates are so low that care workers not only receive low wages, but they don't typically receive mileage, and they're going from house to house. They don't often receive benefits or sick or personal leave. And, to get into this space, you need to have some training. And so some workers are unable to obtain that training because the agencies can't afford to pay for it or pay for the workers' time to attend the training. We are challenged with finding workers, and just within the long-term care space, because we are the lowest paid in the aging space. And then you look at the broader employment situation right now, where you have Amazon and fast food paying $10 to $20 an hour. And then finally, another problem with this workforce is that actually becoming qualified to provide this service is challenging. There's a lot of hoops, and I know the state is working through this and trying to streamline some of their processes and update their systems. But it has been a challenge for people, and it takes months for people to become certified to be able to provide this care. So that can cause a delay. Okay, so next slide. And what does this mean? What is happening right now in home and community-based services, particularly with personal care? People are waiting months to up to 2 years for personal care. People are choosing not to enroll because they don't think they will get the care. They cannot leave the hospital or nursing home rehab safely without supports. Family members are under increased stress. Home environments are declining, and people are simply choosing to go without care. Or it may get to a point where they just decide, I can get the care in the nursing home because that's funded, and or they may become so sick, they're just waiting, they don't have supports, and their health declines and they end up in the hospital. And all of these have an impact on the state budget, but they also have an impact on individuals and their health and aging outcomes. This slide shows that disparity in wages across the different programs. And what we're putting forth, and a number of advocates, including nursing homes and folks in the DD space, we would like to see, not only for Passport, but for all of the workers in this system, to be receiving $20 per hour. We want this to be across systems, across populations, and then with some idea of sustainability. So that is our advocacy point right now in the state budget, and we've had tremendous response from legislators and from folks coming to testify. And I know we're getting close on time, so I am ready to turn it over to Jordan.
Thank you. I get to round us out with the last couple of slides. So as Beth was saying, right, we don't have a mechanism right now, similarly to nursing homes, to rebase. So we, as in you all and us who are advocating the HCBS system, go to the legislature pretty much every 2 years. And between the 2 years, we configure a strategy for advocating in the next state budget to ask them for additional money. I think it is critically necessary that we have some kind of system in place that allows for continuous sustainable wage growth for direct care workers. As Beth was stating too, right, there is a real impact here if we don't pay direct care workers, if we don't provide them access to healthcare, retirement, paid training, paid time off. If we don't provide them access, there's a real impact to people in the system trying to live independently in their homes and communities. And that workforce was exacerbated by the pandemic, incredibly so. As you saw, right, the industry started paying way more in other pockets. You start seeing retail fast food paying $16, $17 an hour starting out. So now this current budget proposes a $16 an hour average wage. But even then, you know, we're barely competitive because at $16 an hour, we're still not getting access to healthcare. There's still not a sustainability package involved. So this needs to be increased really to $20 an hour. So we're getting to a point where we as a workforce and HCBS system can be competitive with the private marketplace and attract people into this system. I heard testimony yesterday from someone, from a provider, who said they did a job fair and they had about 190 or so people come interested in entering this workforce, but only 9 ended up applying because the vast majority are unwilling to work for that $12 an hour average wage within the system. So the need is there, right? There are people that want to access the system. We just don't pay them. Last slide, please. So to kind of round us out, there is a few auxiliary issues. The HCBS system is huge, it's complicated, it's nuanced, but there are also multiple facets of what it means to live in your home and your community and live independently. So in addition to the waivers and the direct care workforce crisis, there remains lack of access to affordable housing. Ohio is a car-dominated state, and so access to public transit and non-medical transportation is limited. For non-medical transit and non-emergency medical transit, you have to schedule weeks in advance sometimes and wait hours at your doctor's office just to move. It takes time to plan out for people to get to the state house, to go to the grocery store. There's a lot there. People can't just wake up and go out and live independently without a number of supports and thought that goes into it to ensure they can live independently. Additionally, underemployment and unemployment disproportionately are impacting disabled Ohioans. And as already stated, right, people are going days, weeks without care. And we are seeing people being forced in a way where, you know, not necessarily they're being dragged into institutional settings, but people have no other options available and they are electing to go into institutional settings because there is nowhere to receive care in the home and community. And I think that is incredibly unacceptable as we continue to, you know, put focus on individuals. You, myself, Beth, most of us on this panel, right? We don't necessarily have to think about, oh, what's going to happen if we don't have access to a direct care worker tomorrow and lose access to our home and our community. These are real issues. And I want to end with just one quote from testimony yesterday, which is, "It's only when you can leave a house every day that it becomes a home, a place you miss. Any place you don't know how you can leave becomes a prison." And I think that particular quote is powerful in demonstrating the huge need to invest in home and community-based services and increase the wage for our direct care workers.
Jordan and Beth, thank you so much for your time this morning. It's been so helpful. I know I've learned so much, and we know, yes, a complicated subject with a very interesting history. But it's very interesting to see where this started and where we've come, and certainly what we're facing currently and the opportunity that exists in the legislature at the moment. I know AOF and I know a lot of our partners are really proud to support the increase in rates and wages for direct care workforce. We hope we can see this through the end. If not, the fight will certainly continue. So we are wrapping up kind of this first section of our webinars. We will be taking a quick break, like I said earlier in the webinar, during spring break. We will all rest and recharge for what will be a very quick last 3 months of the budget cycle. My goodness, I can't believe we're halfway through. But we are excited to be back, and we'll return again with those changes in that first House version, as well as making sure that we continue to highlight and spotlight a number of our members and their issues and their asks that are out in the legislature. We know there's lots of needs out there in health and human services, and we are here to bring you the best information we can. So thank you again. We will be sending around those slides and the full recording after this webinar concludes, and they're always also available on our website at advocatesforohio.org. Thanks again to Jordan and Beth, and to our interpreters, Amanda and Jen. Thank you so much. We appreciate you. Thanks for being here, and we will see you next time. Have a great Friday. Have a good weekend, everyone.
Thank you.